The Colombian healthcare system, a critical analysis in the midst of crisis, illustrated by personal experience. Introduction. Colombia's healthcare system, formerly known as the General System of Social Security in Health, SGSSS, was established in 1993 under Law 100 with the ambitious goal of achieving universal coverage and equitable access to medical services. Structured around a mixed public-private model, it relies on health-promoting entities, EPS, entities that act as insurers, to manage contributions from workers and the state, financing a network of public and private providers. This system has been praised for expanding coverage to more than 95% of the population by the mid-2000s, significantly reducing out-of-pocket expenses and improving key health indicators such as life expectancy and infant mortality.
However, by 2025, the SGSSS faces a deep crisis characterized by financial insolvency, infrastructure deficits, and operational inefficiencies, exacerbated by political reforms under President Gustavo Petro's administration. Petro's commitment to a more state-centered model, including intervention in the main EPSS and proposals to eliminate private intermediaries, has generated controversy, with critics arguing that it has deepened uncertainties and led to service disruptions.
This video provides an extensive analysis and critique of the Colombian healthcare system, drawing on recent developments and systemic challenges. To ground the discussion in real-world implications, it incorporates the harrowing experience of an 80-year-old Colombian woman who suffered a medical emergency in rural Boyacá in 2025. Her case exemplifies the system's failures in emergency response, resource allocation, procedural delays, and infection control, highlighting how broader structural problems manifest at the individual level. Following the analysis and critique, recommendations are offered to address these shortcomings, emphasizing both immediate solutions and long-term reforms.
Overview of the Colombian healthcare system, strengths and structural foundations. At its core, the SGSSS operates through two regimes: the contributory regime, funded by payroll deductions for formal workers, and the subsidized regime, supported by government funds for low-income populations. EPSS collect premiums and contract with service-providing institutions, IPSS, hospitals and clinics, to deliver care. The system's strengths include its emphasis on preventive care through the Health Benefits Plan, PBS, which covers a wide range of services from vaccinations to specialized treatments. International observers, such as the World Health Organization, have praised Colombia for achieving near-universal coverage despite being a middle-income country, with innovations such as telemedicine expanding access in remote areas.
However, the hybrid nature of the system has generated inefficiencies. Private healthcare providers, although incentivized to control costs, often prioritize profitability over quality, leading to denials of services and bureaucratic obstacles. Public hospitals, meanwhile, struggle with underfunding and overcrowding. In 2025, the crisis has intensified. Healthcare provider debts have reached more than 50 trillion Colombian pesos, approximately 12 billion US dollars, with 80% of these entities lacking the required reserves. Medicine shortages affect up to 40% of essential medicines, and hospital closures, particularly emergency rooms and maternity wards, have left vulnerable populations without care.
A personal case study, the odyssey of an elderly patient in rural Boyacá, Genesano. To illustrate the human cost of these systemic failures, consider the experience of an 80-year-old Colombian woman who collapsed in our apartment in Genesano, Boyacá, during a family visit in 2025. This incident unfolded into a nightmare that exposed multiple layers of dysfunction within the healthcare system. The emergency began when she collapsed, leading to an immediate call to the local ambulance service in Genesano. Despite assurances, we waited 45 minutes without a response, a delay later confirmed by the security guards at our residence. In rural Colombia, ambulance response times are notoriously long, often exceeding national averages by significant margins. Studies indicate that rural EMS call times, which encompass response, on-scene care, and transport, average around 93 minutes, far exceeding urban standards. Forced to improvise, we took a taxi to the nearest hospital, the ESE Hospital San Vicente in Ramiriquí, 15 minutes away. There, she was diagnosed with a vascular problem requiring urgent intervention, but there were no beds available, a common occurrence amid widespread shortages and lockdowns.
The staff recommended transferring her to the Medilaser Clinic in Tunja, about 45 minutes further, but refused to provide ambulance transport, citing resource constraints. This refusal reflects broader criticisms of inter-hospital coordination, where rural facilities like San Vicente, already strained by debt and staffing shortages, prioritize self-preservation over patient needs. We resorted to another taxi, incurring unnecessary risks and costs for an elderly patient in distress. At Medilaser in Tunja, the challenges escalated. She waited several days for the initial procedure to unblock a vein leading to the brain, a delay attributable to busy schedules and equipment delays. Later scheduled for a heart bypass, she was prepped early one morning, fasting as required, only to be informed at the last minute that the necessary device was unavailable. This scenario was repeated 3 times in subsequent days, each instance increasing her vulnerability. Such postponements are symptomatic of supply chain disruptions and financial woes plaguing IPSS, where late payments from EPSS lead to unfilled inventory.
Compounding the ordeal, she contracted an infection during her prolonged stay, likely due to unsatisfactory hygiene standards and inadequate screening of visitors and patients. Hospitals like Medilaser, despite serving as high-complexity centers, have faced complaints about overcrowding and infection control, with patient reviews indicating dissatisfaction rates as high as 62%. This infection prolonged her hospitalization, illustrating how procedural inefficiencies cascade into secondary health risks. Her experience is not isolated, but rather reflective of a system where elderly patients, particularly in rural areas, bear the brunt of inefficiencies. In Boyacá, humanitarian challenges, including armed conflict and geographical barriers, exacerbate access problems, with essential care often cut off for thousands.
Analysis of systemic issues, highlighted by the case. Emergency response and rural disparities. The 45-minute wait for an ambulance in Genesano underscores a critical gap in emergency medical services (EMS) in rural Colombia. National guidelines aim for response times under 15 minutes in urban areas, but rural realities, sparse infrastructure, poor roads, and limited vehicles result in delays that can be fatal. In Boyacá, where mountainous terrain isolates communities, EMS coverage is patchy, with reliance on volunteer firefighters or underfunded local services. San Vicente's refusal to transport the patient further highlights the fragmentation. Without standardized protocols for interfacility transfers, patients are forced to navigate the system through informal means such as taxis, increasing risks of deterioration en route.
Resource allocation and procedural delays. The lack of bed availability at San Vicente and repeated equipment shortages at Medilaser point to chronic underfunding. Government interventions in EPSS have led to payment delays, forcing hospitals to ration resources. In 2025, the Capitation Payment Unit, UPC, the premium per person paid to EPSs, increased by only 5.36%, barely matching inflation and insufficient to cover rising costs. This financial pressure manifests itself in delayed procedures, as seen in the thrice-postponed bypass, where equipment shortages stem from procurement problems amid EPS debts.
Infection control and hygiene standards. Infections contracted reveal failures in hospital hygiene, a widespread problem in overcrowded facilities. Debates over health reform in Colombia have highlighted how private interests undermine standards, with inadequate screening allowing the spread of pathogens. In rural IPSs, like those in Boyacá, staffing shortages limit the application of protocols, turning hospitals into hotbeds of infection. Broader contextual factors. These problems are amplified by the ongoing health reform process, which seeks to shift towards primary care but has faced resistance, leading to deteriorating services. Policy decisions, such as minimal increases in IPCS, reflect short-term solutions over sustainable investment. Furthermore, humanitarian crises in regions like Boyacá, driven by conflict, divert resources from routine care.
Criticism of the Colombian health system. The SGSSS, although innovative, is criticized for perpetuating inequalities. Rural-urban divides are stark. Boyacá residents face drug shortages and unpaid staff for months, fostering a two-tiered system where wealthy urban residents access private care while the vulnerable endure waits. Petro's reforms, intended to rectify the failings of privatization, have instead caused chaos, with EPS bankruptcies denying treatment and contributing to deaths. Critics argue that a lack of stakeholder consultation has eroded trust, leaving systems like EMS under-resourced. Financially, the dependency model in EPS creates moral hazards. Profit motives lead to denials of services, while state interventions inflate debts. In primary care, challenges include administrative burdens and misaligned incentives, as noted in recent studies. Overall, the system prioritizes coverage over quality, resulting in preventable suffering, as in the case of the 80-year-old woman.
Recommendations for reform. To mitigate these problems, a multifaceted approach is required. Short-term interventions. Improve EMS in rural areas. Allocate emergency funds to equip rural ambulances and train personnel, aiming for response times under 20 minutes. Implement GPS integrated dispatch systems to optimize routes in regions like Boyacá. Standardize transfers and share resources. Mandate inter-hospital transport protocols with penalties for refusals. Create regional resource pools for equipment, preventing shortages like those of Medilaser. Infection control measures. Enforce strict visitor screening and hygiene audits, with incentives for compliance. Rapid testing kits could reduce hospital-acquired infections. Address financial bottlenecks. Temporarily increase UPC beyond inflation, e.g., 10 to 15%, and settle EPS debts through bailouts conditioned on transparency.
Medium-term strategies boost primary and preventive care, expand telemedicine to rural areas, reducing emergency burdens, invest in community health workers to monitor elderly patients, preventing escalations such as fainting episodes, reform EPS structure, transition to a hybrid model with stronger state oversight, minimizing profit-driven denials while retaining private efficiency, infrastructure improvements, fund rural hospital expansions, prioritizing high-complexity centers in Boyacá, such as Medilaser with equipment grants.
Long-term reforms, holistic policy review, pursue incremental reforms over radical changes, incorporating stakeholder input to build resilience. Explore alcohol taxation to fund health, addressing fiscal gaps. Equity-focused initiatives. Target vulnerable groups such as the elderly with subsidized transportation and dedicated geriatric units. Monitoring and accountability. Establish independent oversight bodies to track performance metrics, ensuring accountability for delays and infections.
Conclusion. Colombia's healthcare system, once a model for Latin America, now teeters on the brink of collapse, as evidenced by systemic criticism and personal tragedies like the odyssey of the 80-year-old woman in Boyacá. From delayed ambulances to repeated procedural failures and infections, her experience reveals a system plagued by financial problems, rural neglect, and inefficiencies. While reforms under Petro seek to rectify the failings of privatization, their implementation has amplified the crises. Through targeted recommendations, encompassing emergency improvements, financial stabilization, and equitable reforms, Colombia can rebuild a resilient SGSSS that prioritizes patient well-being over bureaucracy. Urgent action is imperative to prevent further unnecessary suffering and restore faith in a system designed to protect all citizens.